And again, you're watching Curbside Consult on healthinsurance.org, and I'm Harold Pollack talking with Sabrina Corlette about now the prospect of Health Reform 2.0, which I'm sure will be just as fun as Health Insurance 1.0, except it will be about constraining the things that we like instead of at least offering some people something they haven't had before. It does strike me as a very heavy lift in American politics. Just everything about health reform is a heavy lift. In the ACA, so many of the benefits went to a relatively disorganized and politically marginalized group of people, the bottom third of the income distribution, who are the most likely to be uninsured or underinsured, and also sick people who are just a small fraction of the population. And many of us, if we're not sick, first of all, we don't know. We might have terrible insurance policies that would we would lose our house if we got cancer, but we're not getting cancer, so we have no way of knowing that.
Right.
But we do see when it gets more expensive or more inconvenient. So we have all of those problems, and also we have so much of the population is just totally insulated from the issues that ACA is trying to deal with, whether you're a senior or a professor with a nice health insurance policy that's getting a nice tax subsidy. I'm insulated from both the cost side and the insecurity that many other people face. And so if you want to mess with my coverage, it's basically going to be something that's taking something from me for something that really doesn't benefit me personally. And I think that's a real problem with trying to reform the system.
It is a problem, and that's why it took, presidents since, Theodore Roosevelt have been trying to do it, and unsuccessfully until now. I will say, though, even for middle-class, successfully employed people, upper-income people, there is this, there has been this phenomenon of job lock, right, where people stay in jobs that they may not particularly enjoy or may not feel that it really deploys their talents, simply in order to keep those health benefits, either for themselves or a kid or a spouse who's got healthcare issues. And for the first time, that kind of anxiety that many middle and upper class families may face is simply gone. So people may be unleashed from jobs that, and this is something that there's been a lot of debate about, is that a good thing or a bad thing?
Yeah, that was my next question. Is that a good thing or a bad thing?
Well, we actually recently did a study in collaboration with the Urban Institute in which we estimated that about 2.5 million new entrepreneurs will be created because they've been released from this sort of job lock phenomenon where no longer sort of tethered to those job-based health benefits. They can go off and, create the next, Segway in their garage or elf on a shelf or, whatever it is that they're dreaming about. But it's not just that, right? I mean, it's the mom who'd prefer to stay home with her kids but needs to hang on to that job because of the health benefits, or the 60-year-old who's dreaming of an early retirement but can't because they need to hang on until Medicare. So I completely agree with you that one of the political challenges of health reform has always been that it's focused on this disaggregated, politically disempowered group of lower income uninsured. But there are these. It's difficult to quantify the benefit of sort of easing that middle class anxiety about, gosh, I've got to stay in this job because I need those health benefits.
It's interesting. That also brings out how ACA over time might bring about some pretty large social changes. And if you look at something like this Congressional Budget Office projections of the costs and so on, how tentative those necessarily are, because if suddenly more people start working part-time or whatever the issues are, of course that will have an enormous impact economically and socially, and that's very hard from the 2014 perspective, it's very hard to predict what those impacts will be.
That's right. It's extraordinarily hard to predict, and I think many of us will look back 5, 10 years from now and say, if only we had known. But I do think particularly small businesses, that could be an area where we're going to see a lot of dramatic changes. Small business owners have struggled for years to offer coverage to employees. Many of them really want to do it because it's an important way to get good talent and keep good talent, but it's very difficult, very expensive, and they've struggled. And the Affordable Care Act opens up some new opportunities there, perhaps not in the way the drafters intended. But we're hearing in a number of states about small business owners that are looking at disbanding their small group plan, giving their employees a wage increase, and telling them to buy coverage on the exchange, which they can do because it's guaranteed issue. They get premium tax credits if they're low to moderate income, and it's decent coverage. So it for some small employers, it's going to unshackle them from the provision of health care. Now, that's a win for the employer and a win potentially for the employee, but a loss for the taxpayer, right? Because the federal government picks up that cost.
I was talking with my stepsister, who, by the way, is very disappointed in ACA so far. She works for a pretty small employer, and she thought and she's a big supporter of liberal causes, and her health insurance has basically gotten worse under her employer, and he's blaming Obamacare for it, which seems to me that's the obvious play for whatever you're doing is to blame Obamacare.
Right.
But she wishes that her employer didn't offer any insurance because she can't go to the exchange because he's offering this insurance that she doesn't like. And it seems to me that that's a pretty unstable situation because obviously, once the employer figures out that it's a negative from his employee's perspective, he could just drop it. And I think she would be happy to go on the exchange, and she's just annoyed that she can't do that she's not eligible for the subsidy because of the offer by her employer. Right.
Yeah. No, and that is another concern and something that we're going to need to watch, particularly for large employers that might want to avoid the employer mandate and having to pay a fine. If they don't offer coverage, if they just offer a bare bones plan, is that going to sort of get them out of the mandate, but not make their employees very happy? So that is something that is worth watching, and maybe something that policymakers will need to address if it picks up as a trend.
Now, if you had your druthers and we made you king of the healthcare world, would you just get rid of the employer mandate and just let it go and let lots of, if IBM drops their coverage and everybody goes to the exchange, hey, that's fine?
Well, it's a little bit of an accident of history, right? That anybody has had employer-based health coverage, and that we've been so reliant on the employer-based system, really since the Second World War. And if you look at how other countries do it, they don't do it that way, and it's sort of a crazy way to do it. On the other hand, I wouldn't want to wave my magic wand and make employer-based health coverage go away completely, because I just think that's just a system that people have come to really rely on, and so I think it's one that's a rationally built system that if we could start from scratch and built a rational system, it wouldn't be employer-based coverage. But that's the system we've got, and we can't just eliminate it overnight without ending up with severe disruption and a lot of unhappy people.
Yeah, I think that's right. And I must say that if I had, say, a disabled child, I would really want to wait and see how these marketplace plans are actually working before I had a strong opinion about what I would want my employer to do, because there is a sense that the current system has been road tested more than the marketplaces have to this point. And even though the marketplaces are very promising, I'm sure that there's going to be lots of glitches that have to be ironed out before they really before they're sort of ready for many people who have unusual circumstances to really deal with.
That's absolutely right. And what we've also seen in a number of states and a number of markets is insurance companies dramatically narrowing their provider networks to offer plans on the exchange. And there's a real trade-off for consumers there. Obviously, if you narrow your provider network and pay providers less, you can offer a more affordable premium to people, and that's attractive. But it may mean that important marquee hospitals, academic health centers are not included in the network. It may mean that certain specialists, certain subspecialties and other specialists are harder to make an appointment with. May mean you have to drive further to get care. So, as you say, if you're a parent of a disabled child, that's not been such a problem in the employer-based market. Networks have been fairly robust for a while in the employer-based market, and so that is a trend that we're going to have to watch and just understand whether consumers are happy with the coverage that they have through that marketplace and are getting the care they need.
I have such mixed emotions about that as well for the reasons that you identify. I think that you mentioned that Health Reform 2.0 will have to deal with cost. Narrow networks, first of all, they allow the consumer a more economical policy, but they also give some bargaining power to the demand side of the table. And much as, of course, the University of Chicago should be included in every plan. But the more you require broad networks, it's true that you help consumers when they have someone sick and they need to go to an academic medical center, but you're really undercutting the bargaining power of the insurers to go to the big academic medical centers and saying, you just charge a lot of money for
right.
what you provide. And we often criticize the insurers because they're not covering care at a marquee hospital without asking the accompanying question, well, how much was that hospital charging for that? And that has
right.
to be part of the conversation because academic medical centers, there are some of us where it's like buying your groceries at the movies, and it's just really expensive.
Yeah. Well, and consumers have largely been insulated from understanding the differences in provider pricing. And as you point out, some of these marquee hospitals, the prices they charge are not commensurate with the quality of care that they provide. There's often no correlation. And so I do think now we're moving in a direction with a lot more price transparency, a lot more exposure of providers that are charging really ridiculous prices relative to the healthcare outcomes that they can produce. And we have a country where the political calculus that we have made is that we're not going to have government setting rates for commercial payers. We're not going to have a public option plan. So the only people who can push back against that provider pricing right now are the health plans. And as you point out, if their ability to do that is constrained because they're told they have to contract with every hospital in every town, that's going to lead to increased premiums for consumers.
Now, one last question as we get near the end. What do you think of the Cadillac tax, and do you find that it's having a real-world impact in what you're seeing in the work that you do?
Well, so the Cadillac tax is the 40% excise tax on very, very high cost or generous health coverage provided by employers. It doesn't go into effect in full, I don't think, until 2018, or maybe it's 2017. I can't remember the exact date. I do believe, I don't have any solid evidence except for anecdotes right now, I do believe that a number of employers that do offer this generous coverage are rethinking that. I spoke to one large employer recently who said that they are planning to offer, I think actually just this year, they're offering a much slimmed down plan and giving employees a big incentive to enroll in that plan. So I think that is going to be a trend we'll start to see over the next few years as employers kind of make that calculus that they can't be offering these extremely generous benefits anymore.
And on the whole, do you think that's something that is welcome, or is that something that's problematic?
Well, at the end of the day, it means more cost sharing for employees. That's a trend that's been going on for years, long before the ACA was passed. And health economists would tell you that consumers need skin in the game to over time create the political pressure that we need to address the cost problem. On the other hand, there's really good evidence that shows that when people have really high deductibles or really high cost sharing, they don't just forego unnecessary care. They also forego really important primary and preventive care that's important to keep people healthy over the long run. So, these are really tough questions.
Yeah. Well, we ask the tough questions here.
Yeah, that it's hard to find that right balance. My in-laws recently retired, but they were in a plan where they literally had no deductible and no cost sharing. It was it was through a university. They literally had no out-of-pocket costs at all, and that's in this day and age, that's sort of just not going to be sustainable.
Well, I think particularly for those of us that are, say, in the top third of the income distribution, that we really should see more of those costs. So that it seems to me that the warning that you issued that cost sharing leads people to forego some of the important preventive and primary care that they need. It's really low income people with health problems are the ones where we'd be the most concerned if you say looked at the old Rand health insurance experiment. That was a really disturbing finding there, particularly with things like hypertension and vision and dental care. I think that for a lot of people that can't afford it, it's a somewhat different issue, and that we probably do need to rethink that some, because I actually think that you said that it was very difficult to, we're spending 17% of GDP on healthcare. It seems to me quite possible we could be at 23, 5 years from now, 10 years from now. And that is really, especially given the way we finance healthcare in such an inefficient and disorganized way, that really would be problematic. And so we would have to, in order to make healthcare reform 2.0 successful, I think we really do kind of have to make more visible the economic burden that is putting on the economy and putting on government and other payers.
Right. Well, there's been some interesting work done around what they call value-based insurance design. The idea being, if you've got hypertension or diabetes, that any care to sort of help you maintain your health would be free or almost cost-free, but that less necessary, more elective procedures or procedures that don't have a lot of evidence behind them would come with a lot higher cost sharing. And that kind of approach has a lot of appeal, and it's great in concept, but it can be difficult to execute.
Well, this is a great place to end it. Thank you so much for a wonderful conversation and for the work that you do. We'll put some links up on the website to the reports that you've been a co-author of, a voluminous collection of really informative and judicious, nonpartisan information that I think helps us understand how the marketplaces are going, and I've learned a lot from your work, and it's an honor to talk to you.
Thank you so much. It's a great pleasure to talk with you today.